1, 2, 1, 2. 1, 2.
Stick on recording if that's okay.
Yeah, no worries.
So I'm going to kick off with the questioning.
Yeah.
Completely understand why, but am I correct? So this is all set up and ready to go, but didn't actually start, or did you manage to do a few patients before?
Essentially started the week of the 7th of March, so maybe a couple of weeks. But to be honest, right. I didn't get a chance to see that. Basically, the nurses in pre-assessment were doing the collection for me, which was very kind of them. So I didn't get a chance to go and see them and see what was going on, really.
And so my second question was, you know, the notion of where you can intervene on the preoperative pathway. Mm-hmm. How long before surgery was it, and did you have a look at whether you could meet these patients sooner, kind of closer to the notional moment of contemplation of surgery? Yeah,
of course. So as you can see from a pathway, so the questionnaire is sent out quite ahead of time, so that's why you calculate the BMI. Yeah, to be honest, the waiting list was so long, they was being seen very, quite promptly anyway. So there was plenty of time, a good few months before their surgery date. And to be honest, they wouldn't be sort of past fit anyway, so they had plenty of time to discuss all of these options previously.
So because this is a truly elective pathway as opposed to an urgent one.
There's a small part for sort of an urgent cancer and things like that. I've sort of put that in there. But yeah, generally it's purely elective. And I was just finding that these really quite large patients were being listed for quite inappropriate things without any intervention and without any sort of risk discussion with the patients either. They were completely unaware of how high risk they were going into this.
Thank you. Questions from other folk on the call?
Gwen, what was the most common type of surgery that these patients were going for?
Yeah, that's a good question. So I had a little graph, but I didn't have space to put it all on. So gynae was quite high, quite a lot of obese ladies, orthopedics in general. Those are the 3 highest ones that I came across.
Okay.
I'm not sure if that's that surprising. That's what I tend to see in my day-to-day work anyway. Thanks for the question.
Were any of them, so clearly a lot of it's elective, but were any of them urgent type surgeries where there was a time constraint because of a cancer diagnosis?
There were a few. I haven't sort of subdivided that in my sort of in my results. However, these you can sort of see why they were rushed upon a bit more, and they'd all have pretty much all of those had a consultant review, so it was kind of following the pathway that I've designed. Essentially, that's what we want. We don't want to delay anything urgent that needs to happen. The main point of this is to delay things that are purely elective, that we have got time to modify their sort of lifestyle changes and things like that.
Okay, so I've saved the trickiest question to last. Should you maybe delay, even with some of the cancer surgeries? Yeah. Do you think there might be a case for delaying?
I think so. I mean, it's a patient by patient choice, I think, with that sort of thing. You need to have a full MDT discussion. You need to have the patient on board. You need the surgeon to sort of give you an idea of how urgent it is, because you've got really urgent and then slightly less urgent surgery. If there's if the patient's motivated to lose weight and to address, for example, diabetes as an issue, we can get their HbA1c down, then their infection rate is lower. So yeah, definitely, I think there is definitely space to try and delay if it's appropriate.
Great, thank you very much. And then, if my phone works, that's the end of the 6 minutes. So if that happens when you're speaking, you'll know what's going on. Just in terms of keeping the playing field as level as possible and giving everybody a shot. So the next presentation, I will give you a moment for that person to gather their thoughts, is this one.
That's me.
Excellent. So just if you take a couple of moments, I'll just restart, get the timer ready to start,
Sure.
And if you tell me when you're ready to go.
Yeah, I'm ready.
Okay. Great. Thank you very much.
Morning, everyone. My name is Amit. I'm an ST3 registrar in North East London, and I'm presenting the results of an audit that I carried out last year and the year before, in which we looked at routine preoperative ECG testing in an anaesthetic assessment unit with these patients prior to surgery. The National Institute for Health and Care Excellence sets guidelines for which tests should be carried out on which patients prior to surgery. And so I did this audit to see if patients were having ECGs in line with that, that NICE guidance. What I identified was that there was a significant proportion of patients in our unit that were having ECGs when it wasn't actually indicated. And somewhat more worryingly, I also identified that there were some patients who should have had ECG testing done before their surgery, and they weren't being tested. So I developed an algorithm that you can see in the middle of the screen to help the pre-assessment nurses to decide which patients needed ECG testing and which didn't. And once I introduced the algorithm, I carried out a re-audit. And what I was able to show was that we'd reduced the percentage of patients having unnecessary ECG testing. We also reduced the percentage of patients who weren't being tested when they should have been tested. And we reduced the percentage of patients having ECGs overall. When we extrapolated the figures up to the total number of patients being seen in this unit each year, which is about 12,000 patients a year, it equated to a cost saving of more than £23,000, and also improved our adherence to the NICE guidance. So given how straightforward this was to implement and the amount of money that we managed to save, we felt that this was worth publicising. Thanks very much.
Right. So I'm going to sort of ask my questions back to front now, but the cost saving, so how does that map out in terms of number of patients and what sort of activities? Where were the cost savings?
In the NICE guidance, it makes clear that the cost of an ECG being performed is somewhere between £8.67 and £37. And that takes into account the cost of the ECG machine itself, divided over the lifetime of the machine, the disposables like the ECG electrodes and the paper and the ink, but also the cost of nurse time in terms of carrying out that test and how many staff are employed and so on. And the tariff at this hospital where I carried out the audit was £25 per ECG. And all those ECGs were being done in the cardiac physiology department by an electrophysiologist, which is how the cost kind of came about.
Do you know if you have sort of counterfactual? Well, so one thing is, did anybody have an ECG that subsequently proved to be useful that shouldn't have had one? If you understand what I mean.
I didn't look into that. That's so essentially what I did in the when I introduced the algorithm was I gave the nurses license to perform ECGs outside of the NICE guidance kind of indications, and what I asked was that they would just write a note as to why they perform those ECGs. So there were quite a few ECGs that were done essentially unnecessarily in inverted commas, but the comments included things like irregular pulse, blackouts awaiting cardiology, out of area patient, history of chest pain uninvestigated, history of SVT, recent medication change, palpitations. So,
yeah.
Kind of relevant indications to perform an ECG just outside of the guidance. And actually, if you were to exclude those patients and discount them from the audit, then it would show an increase in the patients being managed according to the guidance. In terms of the flip side, I didn't look at whether unnecessary ECGs identified pathology specifically.
Right. But what you, so I think what you just said is that so sometimes the nurses acted outside the guidance, and that was actually probably appropriate and reasonable.
Yes, absolutely.
Yeah.
And we gave them full license to do so. They're clinicians at the end of the day.
Sure. Any questions from others on the call?
I was just going to ask the opposite. So the ones that didn't have an ECG that should have, did you have any particular critical incidents or anything bad that
Not that were flagged up that were directly related to the patients we saw. I mean, I didn't look at critical incidents in the hospital and sort of cross-match that to the patients that we looked at. But there were a few where there were kind of, to be honest, a lot of them were in patients with asthma, and without actually physically seeing the patient, it's very difficult to know whether they're on, you know, once daily salbutamol or once monthly salbutamol, whether they're on full treatment for severe asthma with previous kind of intensive care admissions. The guidance is vague in terms of the comorbidities that we're looking at. and they're not particularly specific, which was I think a limitation in terms of what we're doing here. And that's the reason that we gave the nurses license to work outside the scope of the guidance.
Right. And as someone who's immersed yourself in, as you do when you do these projects in this area, do you think the NICE guidelines are spot on and fit for purpose, or would you actually be now thinking about changing them a bit?
The evidence upon which the guidance for ECGs were based is not the strongest evidence the world's ever seen. So there's room to change it, but overall I think it provides a reasonable guideline. I wouldn't necessarily call it an algorithm that must be followed at all costs, but it's a useful guideline to handrail from. Thank you. Thanks very much.
Thanks very much. Okay, so I'll move on to the next presentation, give somebody else a few seconds to work out who it is and when they're ready to. I'm conscious that I think we've got one less person on the call in our presentation. So is this someone on the call?
Yeah, that's me.
All right, now I can't see which you is that?
Sarah.
It is Sarah. Okay, I can see Sarah now. Yeah, sorry, your picture. Are you happy and ready to go?
Yeah, good to go.
Brilliant. Okay, off you go. Thank you.
Thank you. Hi everybody, my name is Sarah Moore. I'm a clinical specialist physiotherapist working in St James's Hospital in Dublin. So we started the OpFit Prehabilitation program a year ago here in the hospital, and pre-COVID it would have consisted of one-to-one physio assessment and treatment and a daily exercise class. But since the onset of COVID-19 in Ireland in March, it's been necessary really to restructure the workflow. As these patients were still waiting for cancer surgeries and cancer surgeries were continuing, there was a need to continue with the prehabilitation service for these patients. So we decided to switch to virtual prehabilitation for these patients. So during the first 3 to 4 weeks of the pandemic, I was redeployed to the ward setting, but in the background was working on protocols and processes to get this virtual program up and running. So we ran the first class on the 23rd of April. And since then, we have had, well, in the first 6 weeks of the program, we had 71 referrals. Of these, 19 patients attended the virtual program, and most patients attended approximately 4 classes, and you can see there the median age was 58. So the pie chart there shows the outcome of referrals. So all patients would be referred from their surgical team to the program, and then they are screened by myself either over a video consultation called Blue Eye or over the telephone for suitability for the program. So we've been running a daily exercise class on Zoom every day for this patient group, and we find that it's safe, it's feasible. Informal feedback has been really positive for these patients, but as you can see there from the pie chart, there was 22 out of the 71 patients didn't have access to a device so that they could connect to the call. So we find that this has been an issue, so our work going further forward will be to look at how we can get remote access for this patient group. We'd also like to look at it a more in-depth analysis of the benefits and the outcomes for patients, and see going forward, is telehealth better than face-to-face? Is it the same? And what we can work on after the COVID-19 crisis. So that's everything.
Great, thank you. So I'm going to start with the challenging questions. How do you know it's safe?
To date, in the first 2.5 months of the program, there hasn't been any adverse incidents, and we ensure that all patients read through a safety checklist and they sign a disclaimer. So since then, there hasn't been any issues with patients, and I suppose, going forward, it is something to look at, but to date, it has been okay.
So they're all still with you, they've all got to their operation, those that are...
Yeah, they've all got to their surgery date, and yeah. And
that's a good start.
Yeah, always.
And have you had patient feedback either formally or informally?
So we've had informal patient feedback. We were running an audit between all the outpatient services on telehealth in our department, because it's not just the prehab service that has had to switch, it's all outpatient services here. So we have done an informal audit, asking a couple of questions around the actual connection to the call, audio, video, was it easy to connect up to? And then also, did you feel it was safe? Did you feel it was an effective way to get your physiotherapy? Would you like this going forward? So there's only been 5 patients analysed, as part of my audit, and they've all had really good feedback from it. They all found, you know, during COVID-19 they were trying to cocoon, they all had cancer, they were going for surgeries, and they found it a good way to get their physio, but also to connect with other people and have the support of other patients who were in the same boat as them.
Thank you. Questions from other folk on the call?
Just to ask, have you done any work or thought about doing any work really around the cost effectiveness of the intervention? Because obviously the one-to-one assessment and treatment and in the daily classes, I assume has a cost attached to it. Is that something you've looked at or?
It's not something we've looked at yet. What we were thinking is, you know, some of these patients St. James's is the only hospital in Ireland actually that has a prehab service at the moment. So a lot of our patients would be from further away. They would be traveling to the hospital. You know, there'd be expenses in terms of travel, in terms of parking, you know, that sort of thing. So I suppose this looks like it could be beneficial in terms of cost saving, but again, it's hard to know. In other terms, maybe people aren't able to attend the virtual classes without access. So it's hard to know which one is better than the other, but we haven't looked at it yet anyway. Thank you.
Sarah, I was just wondering, you mentioned cancer patients. Is that all, do you have like an inclusion or exclusion criteria? Is it all cancer patients or more comorbid patients?
Yeah, so it's actually cancer surgery patients. So it's once patients have a confirmation that they're having surgery. And so our biggest patient group would be lung, upper GI and colorectal cancer surgery patients. We would also have some head and neck gynecology, breast cancer patients as well. So some of them would be going through chemotherapy at the moment, but with the end goal of going to surgery. So they might be having neoadjuvant treatment, but they can still do the program then. So it wouldn't be patients who are just having treatment and not having surgery. It's all patients who are waiting to go for surgery with the aim of optimizing them before they get to that date.
And do you think this is something that you will, post-COVID, that you'll do all of it, some of it, none of it?
I definitely think it's something that we had talked about before but never quite got round to doing, and I really think there is a huge benefit to it. Like I said, a lot of our patients will be traveling from the middle of Ireland. It might take them 2 to 3 hours to come up. They're not going to travel every day for an exercise class. So what my hope is going forward is that soon enough we can start having one class where patients come into the gym and do the program, and then a second class maybe for more rural patients who can't make it to the gym setting, that they can engage in the virtual exercise class.
Maybe a bit of, because we, you know, we do a bit of prehab stuff in Southampton, maybe a bit of mix and match for the patient, so you bring them in occasionally, but
yeah, exactly, because it can be quite tiring for them traveling in every day, you know, especially if they're having neoadjuvant treatment. So it might be good if they could do some days in here and some days at home virtually as well. Definitely.
Great, thank you very much.
Thank you.
So next presentation.
Oh, that's me.
Yeah, you take a moment to compose yourself and then tell me when you're ready to go.
Yeah, I'm happy to go. Hi, all. My name is Aalekh. I'm one of the registrars working at Ipswich. This was an interesting case report we came across last year when I was working in India and doing my training there. So this was a 21-year-old who came in history of headache and vomiting for the past 5 days. He was a known case of TOF and with no surgical repair and a poor effort tolerance. On examination, he was maintaining his airway. On breathing beds, he had a SATs of 89% on room air. He had central cyanosis, as you can see in the picture. He had a blood pressure of 130/80 and a heart rate of 72. So hemodynamically, he was stable. On examination, he had his apex beat, which was in the 5th intercostal space in the mid-clavicular line. And he had a left parasternal heave with a pansystolic murmur. His DCS was 15, and on peripheral examination, he had clubbing, as you can see in the picture. On airway exam, his mouth opening was 3 fingers, and he had a Malapati score of 2. Labs-wise, he had a hemoglobin of 209, hematocrit of 61. Coagulation was fine, white cell count was fine. X-ray shows a characteristic boot-shaped heart. So he also had an echo which showed that he'd got a large VSD of about 0.7 millimeters with 60% overriding of aorta, RVH and RVOT obstruction. And on CT brain, it showed that he'd got a 4 multiplied by 5 and multiplied by 5 centimeters SOL in the left-sided temporoparietal region with a minimal midline shift. So in theaters, as you can see on the screen, he had heart rate of 93, his SATs were 89. So we, first of all, we did an IV cannula on him because his hematocrit was a bit high. That can be because of the polycythemia, but he was also vomiting for the past 5 days. So we loaded him with some Hartmann's. We started him on oxygen with, at 5 liters per minute via face mask, and antibiotics were given for infective endocarditis prophylaxis as per the local policy. Then he had some sedation, and we decided to do a PICC line and an arterial line on him. And followed by that, he had sedation with fentanyl 50 mics and 25 milligrams of ketamine. And then a scalp block was given with 60 milligrams of 0.5% bupivacaine and 80 milligrams of 2% lignocaine. So intraoperatively, he was absolutely stable. We had all syringes and IV tubes, made sure that they were bubble free. We had defib pads and vasopressors on standby, and nasopharyngeal airway and IGL standby in case if it's needed. So effectively, the time of surgery was about 30 minutes, so it wasn't a very long procedure. And although I would like to say that GA would have resulted in a better outcome, better oxygenation maybe, but all GA drugs would have caused decrease in SVR, and positive pressure ventilation would have caused increase in PVR. So in a patient who's already got right to left shunt, probably scalp block and sedation turned out to be a good plan for him. That's it.
Great, thank you. And so you said you thought a GA might give better oxygenation, but I mean, from what I mean, it sounds like you maintained oxygenation pretty well.
He was oxygenating fine with 95%. Yeah.
So my main question is, what was Plan B? Like, if things started going really pear-shaped, were you ready for a full cardiac anaesthetic approach, or what was the?
Yes. So this is in neurosurgery theaters, and so we have the cardiac surgery theaters on the same floor, and we've got a cardiac anaesthetist standby. And this was an emergency procedure, so we didn't have time for medical optimization or a cardiac catheterization for him, but we had people on standby, definitely. And from an airway point of view, we had NPA and an IGL necessary. So this is almost similar to what you would do on a patient with, who's having an awake craniotomy. So we do a lot of that as well in India at the center I used to work, so it was okay with that.
Great. Questions from others on the call?
I'm just thinking, did you find out the cause of his abscess? Was it related to his tetralogy fallow, or was it?
Yeah. So yeah, his abscess was related to his TOF, because if you've got a right to left shunt, you are prone to infections and cerebral abscesses in any case. So, interesting bit is this patient is 21 years old and he's still got an uncorrected TOF. So that might have been a thing. And it might be just an acute presentation, but it might have been going on for a long time.
Is there a reason he didn't have it corrected?
I guess it's just a follow-ups, and because he came in from a very remote village in India, so may not have access to healthcare as such. Yeah. That might be a reason.
Fair enough. Yeah, thank you.
Any other questions? I guess are you working in, where are you working at the moment?
I'm working at Ipswich now. I'm working here as an MTI. Right. But this was when I was doing my training back home in India.
Yeah, I guess I was going to ask a question as to whether if you encountered it again, but I suspect you'd be unlikely to encounter an uncorrected.
Unlikely to encounter, yes, absolutely.
Yeah. And have you had it? Is this an isolated experience, or is this?
This is an isolated experience with me, but I've read several papers online, and there are people who have been doing similar work, and a lot of them have done just scalp block and sedation for these patients.
So if a patient came in Calcutta now, they would that would be the standard approach.
Yes. Yeah.
Great. Thank you.
Thank you.
The next one, is that someone? Lots of mystified looking faces on the. I'm sorry, I don't know the first name, but is H. Llewellyn or I. Follicus out there, or it may be that they couldn't dial in, so I can't see them on the call. Okay, I'm going to move on to the next one. Ben?
Yes, that's me.
Yeah. Good. Great. Okay, if you take a moment and then tell me when you're ready to go.
Yeah, ready whenever.
Great, thank you.
So hi there everyone, my name is Ben Stanley. I'm a fourth year medical student at the University of Birmingham. And my project was an audit to assess News 2 scoring at the Royal Orthopaedic Hospital in Birmingham. So News 2 is a National Early Warning Score 2, and it's an update to the original News scoring system, a validated tool to assess deteriorating hospital inpatients and therefore escalate them as appropriate. So I'm sure you're aware it assesses 6 physiological parameters, scoring each from 0 to 3, and then coming up with an overall score which can then be acted on as appropriate. So in terms of updates to News 2 from the original News, kind of 3 main areas. So there was addition of a new confusion definition to the AVPU assessment of consciousness as a way of recognising more rapidly deteriorating patients. There's also the addition of a second oxygen saturation scale. So this is a scale for use in patients such as those with COPD, where patients score News points for having an oxygen saturation that is both too high as well as too low. If that makes sense. And the other main update was a more formalised escalation process for deteriorating patients and more formalised documentation of this. So this project looked really at how well charts were being filled in for post-operative patients at the Royal Orthopaedic Hospital. And we looked at 4 main areas of the chart. So it's the baseline parameters, which are filled in preoperatively, documentation of which scale the patient is on, which oxygen saturation scale, so either the usual one or the one, as I said, for patients with COPD, for example. Then we looked at the charts themselves, so the main body of the chart, with the patient observation of the 6 parameters and the total scoring. And then we looked at where appropriate the patient escalation documentation, whether that was being filled in. So the main findings really were that the charts themselves, so the kind of the main body and the total scoring were filled in well. So there was 93% completion of those with a 91% completion of the total score. And that's pleasing really because it allows News 2 to carry out its function in a way to identify deteriorating patients and then allow them to be escalated as appropriate. Conversely, however, some of the other areas of the chart really weren't filled in very well. The preoperative patient baseline was not fully completed in 89% of cases. And obviously that's an area of concern because if we're not defining a baseline for a patient initially, it's then more difficult to kind of ascertain deterioration from that baseline. Similarly, the oxygen saturation scale was very poorly filled in, so just 9% of cases were actually documented which scale the patient should be on. And obviously if they should be on the second scale, if they're CO2 retainer, for example, and that's not documented and they're over oxygenated, that obviously has real tangible risk for that patient. And finally, the patient escalation documentation wasn't filled in adequately either. So this was just 3 cases of patients who scored a News score, so that's of 5 or greater, where they should have had an urgent clinical assessment, and this was only actually documented in 1 of these cases. So it may well be that the patient was escalated and it's just not been documented, but either way, that's still something that obviously we need to improve on. So in terms of recommendations moving forward, there are kind of 3 main areas that we want to pursue. So we want to develop the audit itself a little bit further by really getting staff involved. So we want to kind of assess their knowledge and understanding of News, looking particularly at the adaptations for News 2, because it was these areas that were quite weak really. So the escalation documentation, the oxygen saturation scale, they're new things that have been brought up relatively recently, so it's those we want to focus on really. So following this survey, we'd then like to do a staff education programme, and again highlighting the importance of completion and really focusing on why it's important for patients. I think sometimes there can be a tendency for, especially kind of the areas of the form away from the main chart itself, to be maybe a bit of seems a bit of an inconvenience and more paperwork to do. I think we really need to hammer home the real tangible patient benefits of filling it in, or the harms that can be caused from not filling it in. So yeah, there'll be different strategies for this. So we look at posters, things on the Trust intranet. We work doing face-to-face teaching, but obviously that's more difficult at the moment. And then yeah, following this, we'd look to re-audit in 6 months' time, see what progress has been made, and if any further work's needed. Thank you.
Thank you. Great. So starting with the not completed bit, obviously it's useful. It's more useful for some measures than others to have a baseline.
Yeah.
And I just wondered if how you feel the completed bit mapped onto the utility, if you see what I mean.
Yeah, so we did, I've not did on the chart, but we did do kind of sub-analysis of which areas weren't completed. I think one of the most concerning ones for us really was urine output was the most commonly omitted. And obviously that can have implications in terms of AKI and things. So that's one that certainly we'd identify as useful that wasn't really completed optimally. I think obviously that's the reason for that is it's much more difficult to ascertain than many other things, but it is just an estimation of urine output that's required for the chart. So I think that's something we'd really want to focus on in particular. The other kind of parameters are very similar to the ones that are collected kind of 4 hourly, however often it would be, which are quite easy to. Sorry.
Was blood pressure well collected? Because that's one where you often are thinking, you know, what was their blood pressure before? Should I be doing something, or actually is this normal for this patient?
Yeah, that is on the baseline parameters. Yeah, I think for most patients that was collected. It was mainly urine output and hemoglobin as well were the most commonly omitted.
Great, well done. Apologies to anybody else who wanted to ask a question. The 6 minutes.
Yeah, sorry, my presentation was a little long there.
No, not at all. Very well done. Now, I think you probably noticed I saw something flashing, and I hope someone else has joined the call. I'm going to go back one and just check that it's not the person from the previous presentation. I can't see anyone extra on the call, but I thought I admitted someone extra.
There is someone extra there.
Yeah. You've added us. It's Asmie and Yewku from Colchester General Hospital.
Hi, okay. So this is not your presentation?
No.
Okay, that's good. So it's just we'd passed this one already because there was nobody there. And I apologize if you've been in the waiting room for a while. Please accept my apologies.
That's all right.
If I just recap the how this works, and then we'll see. I'll see if when your presentation comes up, because I have a PowerPoint screen which I'm screen sharing. So it's 6 minutes each. Ideally, a relatively quick summary, so 1 or 2 minutes for you to run through the key points of your poster, and then I and others on the call will ask questions within 6 minutes. And I've made a general plea that everybody be constructive rather than critical, so we can all learn from this. So let's have a look who's coming up. So this one we've just done from Ben. Is this you guys?
Yeah. It is.
Good timing. Okay, so you have take a moment just to sort of compose yourself, and then if you let me know when you want to start, you've got 6 minutes.
Yep.
Great.
So, hi, I'm Dr. Enchill-Yawson, and this is Dr. Asmie Vanajaraj, and this is our audit that we've done, NT-proBNP screening in pre-assessment clinics.
So what are the background behind our project is that because we were working in anaesthetics and ITU, we noted that before surgeries and operations, there would be pre-assessment clinics. And one factor that is important is cardiac failure. And the test that's most common and gold standard for cardiac failure is the echoes. However, the contraindications of echoes, or the main reason why we try not to do it as much, is because of the budget of the NHS and the cost of an echo. So currently, both the treatment and the echo of the cost of the echoes is quite expensive compared to another test that's called NT-proBNP testing. So this is a test that tests for the enzymes in heart failure, which is a good, also another good test for heart failure, but it's also very efficient because it's a blood test and it's also much cheaper than doing an echo. So we instigated a protocol last year which shows if someone is coming with any symptoms of heart failure during a pre-assessment clinic, rather than going straight for an echo. So if you can see in this poster, it's got a little diagram of whether they have had heart failure diagnosed in the past, and if not, then you do go for NT-proBNP testing. and depending on those results, so in our protocol, if it's less than 400, then it will be double checked with an anaesthetist whether it's appropriate to have an echo. And if it's more than 400, it's more indicative of heart failure. So that's when you go and do an echo. So then we went through all the different amounts of echoes and pro-BNP testing that was done since the protocol was instigated.
Yeah, so essentially, as we just said, if we want to see if the blood test had an effect on the subsequent number of echoes done, which it did. So the number of echoes in 2019 had decreased by around a third from the same 3-month period that we looked at the previous year. Using price estimates, this could save the NHS up to £70,000, which we thought was quite impressive. And sort of looking at the table, if we take of pro-BNP tests done, but we focus on the negative ones, so those that weren't followed by a test, so it'll be column 1 minus column 3, and we add it on to the number of echoes in 2019, column 2, we roughly more or less get the figure of the echoes performed in 2018, which is the final column on the right. So that's just a quick summary, but all in all, basically the number of preoperative echoes in 2019 has reduced, and by implementing the blood test, we could save a lot of money and time for the NHS.
So during this audit, we wanted to check the nurses' understanding of the actual test NT-proBNP and why they exactly do it. So we did a survey for all the nurses that hold the pre-assessment clinics, and asking whether they know why they're doing it and whether they feel comfortable when to do it. And the majority of them did say that they understand it very well, but they would benefit from a refresher course. So that's something that we'll look for in a re-audit afterwards. So in conclusion, we've noticed that after instigating this new protocol, we've reduced the number of echoes and still been able to diagnose or whether there is heart failure or not without using such expensive testing. So yeah, that's it.
Great, thank you. Do you know, I mean, there are obviously different ways that being diagnosed with heart failure may impact your management around the time of surgery, including anaesthesia. But do you know of any of the people you screened out, so didn't have an echo, subsequently ran into trouble? You know, is there a payoff in terms of the cost saving potentially around outcome, or is that uncertain at the moment?
That's uncertain. So when we've looked at the numbers we looked at were all the people that were seen in pre-assessment clinic. We did check whether people who did have a pro-BNP test but still had the number less than 400, and they still went on to have an echo. So it could be that the anaesthetist may have assessed this patient depending on their symptoms and still said, okay, we should have an echo, even though the pro-BNP was less than 400. So it wasn't just based on the BNP testing, it was also depending on the symptoms. So if you look at the protocol, it says whether they've got shortness of breath, difficult swelling of the legs. So if they had these symptoms and they had a pro-BNP that was less than 400, an anaesthetist or another clinician would further review this patient and see whether this is appropriate for an echo. So I don't think, depending on the symptoms, that they were left off in being treated for heart failure, but I guess we can look at that as well.
Yeah, it's just taking into account the whole sort of clinical picture and just streamlining those that have heart failure symptoms straight to having an echo. Yeah.
Thank you. Any questions from others on the call?
Yeah, I've got one. Thanks for the presentation, it was really good. I have a question about the patients who were reviewed by an anaesthetist after having a low BNP level. Of those, the ones that subsequently went on to have an echo, were they included in the total number of echoes performed? Or we're talking about sort of a net versus a gross cost saving?
So everyone that had an echo that didn't have a pro-BNP were also included in the results. So if there's a column that says the number of echoes that didn't have a BNP, even though if they if we had the raw data, so those people who still had a pro-BNP that was less than 400, we included those people in the data that subsequently had an echo after as well.
So that's a net cost saving then?
Yeah.
Great, thank you. Your 6 minutes is up, but thank you very much for your presentation.
Thank you.
Thank you.
And apologies if you were trying to get in for longer and couldn't.
That's okay.
Esmore, are you on the call?
Yeah, that was the second one of mine, but I don't think I was going to present it. I was just going to do the one. I can do this as well if you want to, but
it's entirely up to you. It's an opportunity, not a threat. So however you feel.
Okay, I'll leave it. It was just a summary really of the program that we started a year ago. So I think I've kind of covered most of that anyway during my first one.
Completely understand. And I think that's it. So you still there? Yeah, good. My screen went blank for a moment.
Yeah.
First of all, thank you very much for presenting. And you're actually our first guinea pigs of doing this remotely. So we've got a whole load of sessions over the next couple of days, but this is the first one. So it is possible I was nearly as nervous as you were as to whether it would work properly or not. So thank you. One thing that'd be really useful is just any, I know it's immediate, but any informal feedback as to how it ran and how how you feel this is of value or not, or just so we can try and improve things in subsequent conferences. So any comments, critical or not, very welcome.
I've generally enjoyed it. It's been really good, really convenient. You don't have to travel anywhere, which is quite nice sometimes. So yeah, I've enjoyed it. Thank you.
Yeah, it's been really convenient, and yeah, it was really nice. Yeah, absolutely, agree with that.
Yeah, same here. Really thought it worked really well. I think you having all the presentations and then just having it on one PowerPoint was much better than individual people screen sharing and things. So yeah, ran really smoothly.
Brilliant. And the 6 minutes seems reasonable, or did it feel too short, or about right?
I thought it was just about right, really. Yeah.
Yeah.
It allows you to give a good, quick, succinct overview of your work and then invite a few questions. So it's a good amount of time.
Okay. Well, if you have any reflections otherwise, or a bit more negative that you don't want to express openly on a call, feel free to ping us an email and just let us know, because it's always useful to try and improve these things. And thank you all for your time and your comments, and particularly for all the work you put into the presentations. They're really good to listen to. So thank you for your input.
Thank you.
Thank you.
Have a good day.
Bye. Bye.
Bye.